Perfect. Well, thank you so much, everyone, for joining us today for Pediatric Facility Recognition Session number 3, Successes, Challenges, and Lessons Learned from our Q&A panel. Today with us, we have our EMSC program managers that have discussed pediatric recognition in a little bit of depth previously. I'm just going to introduce them. We've got Victoria Barnes from Connecticut. We have Evelyn Lyons from Illinois, Brandon Kelley from Wyoming, Candace Facemyer from West Virginia. Also with us, we've got Sessa from New Hampshire, Debbie Kuhn from Nebraska, and Natasha Kurth from Tennessee. With that, I'm going to go ahead and let Vicki get started with questions from our panel.
Thank you, Jane. So I'd like to introduce everybody to Debbie Kuhn. Debbie is one of our probably longer serving program managers from Nebraska, and she's going to lead us in the question and answer panel today. So take it away, Deb.
Thank you. Can everybody hear me okay? All right. I understand these are questions that some of the program managers have asked, and we're going to try to answer your questions, so bear with us. So the first one, what stakeholders and partners did you work with to help garner buy-in among your EDs? Anna, you want to take a stab at that one first?
Absolutely. Good afternoon and good morning to some people as well. So here in New Hampshire specifically, while we do a regional, or we're working on our regional recognition facility program, in New Hampshire specifically, it's been a little bit more extensive because I sit at an academic center and not at the Bureau of EMS. So I've had to work hand in hand with the Bureau of EMS, which also includes emergency departments. So it's not just pre-hospital care that our Bureau works with. So I've worked directly with them a good bit. They have a medical control board within the Bureau, or is run by the Bureau, that includes emergency departments as well. So I've reached stakeholders through them. And then the New Hampshire Hospital Association, and my understanding is that most, if not all, states have a hospital association. So they're, of course, a great resource to reach out to garner stakeholders at the hospitals proper. If you have a hospital, or excuse me, an Office of Rural Health, they will also be able to help you reach the more rural emergency departments. I know a lot of states have EMS regions. If you have regional leaders, you can reach out to them to then disseminate to their facilities that fall under their umbrella. And then some others that I just listed off. So your specific chapter of the American Academy of Pediatrics, your representatives for the Emergency Nurses Association. We have medical resource hospitals that have a group of EMS pre-hospital agencies that they work with. So you can reach through, if you have EMS coordinators, they're a great resource. Injury prevention programs can definitely help you out reaching additional emergency departments. And then behavioral health organizations and other state level pediatric groups. So if you have like family-centered care organizations, they can also help you with reaching out to emergency departments. And then we here in New Hampshire do a simulation training program called IMPACTS, which is improving pediatric care, acute care through simulation. And that is definitely, it offers some education via the system-wide assessment. So that's definitely been a program that has helped us reach out to emergency departments. And that's all I have.
Thank you, Anna. How about Candace? What about your state?
Hello, good morning or good afternoon to everyone. So like Anna, we also reached out to our hospital association. They hold regional meetings. We have 7 regions here in West Virginia, and they always try to make that a part of their agenda to kind of bring that up. And that's been one of the ways that we've gotten feedback on how we can better support hospitals. Some of our other key stakeholders are our EMSC medical director. He also works at one of our very large hospitals that has a NICU and a children's emergency room. And so that's been really helpful because he also sits on various other committees throughout the state. We've also engaged with our trauma coordination and designation division with the Office of Emergency Medical Services. They also hold regional meetings and are in constant contact with the hospitals. So we're really just trying to work with people that we know already have those communications open, so they can just kind of plug in our facility recognition program as they go about what they normally do.
Great, thank you. How about Natasha?
All right, so we in Tennessee, we also work with a lot of the organizations that Anna and Candace had mentioned. We also work very closely with our healthcare coalitions, so they help share information and stuff for us. One of the things that's unique for Tennessee is our program is built into the legislation, and so our advisory committee reports to the licensing for healthcare facilities in our state. And so they have been a huge champion for the program as well. So any hospital that wants to be able to get a license, they have to participate. So that's been a huge help for us in getting people to participate in the program, and they do their self-designation. So a lot of our advisory committee members are very important to us and be able to help share that information as well.
Great, thank you. Let's go on to the next question. Brandon, what approaches did you take with hospitals that contributed to a successful startup of your state's program?
I'm sorry, I had to unmute. I would say my top three were the first was engaging in conversation. One of the first ways I introduced this program is I state out loud, I am not Jaco, and the very first moment you see me behaving like Jaco, stop me, right? I wanted them to feel very much like this is a partnership between me and them, and that I'm with them, right? I will help them write a policy if they need one. I will seek out resources for them. I'm here to help them do this. I'm not here to push them. That was number one, being an ally and a friend and a partner in this, and not the state telling the hospital what it is I want them to do. The second is, it goes all the way back to as long as I've been with the EMSC, it's finding a champion. It doesn't matter who they are, what they do in the hospital. Find one person who cares and work with them. Give them everything they need to be successful, and that has worked great for me. For those places where I've had a lot of resistance from higher up in the hospital, I defeated that, and some of them I'm still in the process of defeating, by simply finding someone who cares, who doesn't mind speaking out about why it's important. And the third is utilize your funds, tools, and resources to not to give them things, but to give them infrastructure, right? This is a road they have to drive on. So to me, my job is to help them build the bridge that's going to cross the gaps, right? So instead of spending all kinds of money putting on PALS classes, spend all kinds of money training PALS instructors in their hospitals. That way they can do their own PALS classes, right? Partner, and you also get there by partnering with your state's trauma program to do some of the trauma courses they have there. And every time you get in front of them, you say, hey, you're from X and X hospital. Have you got this recognition document? Have you talked about this in your hospital? How can I help you do it? Do you want to do it? Just be annoying.
Very good, thank you. While you're unmuted, how about, did you find a top to down or bottom up approach work better with your hospitals?
Bottom up, hands down. Without a doubt, it is so much easier to find people at the lower levels of the hospital that are interested in this and see the value. And it's not a mark against the CNOs and the CNOs. They have other stuff to do, and they don't typically think about the minutia. But in Wyoming, I even applied that bigger, not just in an individual facility. I applied that to my entire system. So I started with the smallest hospitals I could find. And the reason is because in those small hospitals, it's easier to find the champions, right? They have likely, if there's a bad thing that happened with a pediatric patient in their hospital that would give them the intrinsic motivation to want to be involved in making the system better, odds are they knew that kid, or they knew that parent, or they had a relationship with them, or they took care of them, right? It's easier to find champions, at least from my point of view, in the smaller facilities. And then you get the cascade effect. When a small hospital who's near a big one pulls something off that the big one hasn't put any effort into, the big one will come to you because they want the PR that the little one just got.
Great. Evelyn, what about Illinois? Top down or bottom up?
So actually, we found that we needed to take both approaches. I agree with Brandon that we definitely did not want this to look as though it was the state coming out and dictating what we wanted the hospitals to do. But at the same time, we needed to identify the entity that was going to be responsible for facility recognition, so that would be clear and transparent from the start. And so our state health department was determined to be the entity that would have the authority to designate hospitals, since they do that already with other programs. And so they would be not only doing the designation or recognition, but they would also be responsible for the adoption of any regulations that that would be utilized for our facility recognition program. And so that's kind of like the top-down approach, but at the same time, our state's divided into 11 regions. And so we decided, with the volume of hospitals that we have in our state, that it would actually be, it would streamline things if we approached it on a region by region basis. And we also got an advocate, as Brandon said, from within the region. So someone who was well-known, well-respected, and someone who was supportive of facility recognition, so that they could speak to the process and also help to engage the other hospitals in the region. And so having that local advocate really helped to move the process forward at the local level. And then we continued on a region by region basis to bring the hospitals on board with the process. And then in addition, in order to develop the criteria, the requirements, how we were going to roll it out, and the process, this was, at the very beginning, we again didn't want it to be something that the state was dictating. So a task force was convened, and the task force was represented by state chapters from AAP, ACIP, ENA. We also had family practice, advanced practice providers. We had folks with transport and critical care expertise. We also brought on board representatives from our trauma program within the state, as well as the perinatal program, because they obviously have already built an infrastructure. So we wanted to find out what were their lessons learned, what could they provide us to help as we were developing this process. And so that was the group that actually developed the criteria and the requirements. And so we used to relay that to the hospitals then, so that they had an understanding that the process was developed by their own peers, by physicians and nurses and others who work in the hospital, and that it wasn't developed by the state. So that was an important component to emphasize, and that kind of assisted with that bottom-up component.
Great, thank you, Evelyn. So we have a bottom-up and both approach. Tasha, what about Tennessee?
So Tennessee, we did kind of a mix as well. We worked with the state on needing the requirement of putting this together, but we used all of our stakeholders as part of our advisory committee to actually create the guidelines of what would be, what each of the different levels would entail and what would be required to have the different designations. And so we had all the buy-in from the hospitals for the bottom-up approach, but we also had kind of the top-down where they were told this is what we're going to have to do. So it kind of forced everyone to get together, have those conversations, and work through and figuring out what those different standards were going to be.
Super, thank you. Remember, if you have any questions, be sure and put them in the chat, and Jane is monitoring that, so your questions can be answered. So we're going to move right along to the next question, which is, what marked increases have you been able to show? How about Anna?
Yeah, so our program is clearly still really in the infancy stage of the, compared to Evelyn's 20-year program. So we haven't really been able to make any quantitative measures on increasing anything really but engagement. But I can tell you that we already have 4 facilities. The NPRA closed 2 days ago, and we already have 4 to 5 facilities who are already submitting their commitment letters. So engagement for other efforts around EMSC, so guidelines, agreements, NPRA efforts, all of that has definitely increased as far as the engagement we've had for other efforts aside from pediatric recognition. So I think that the pediatric recognition facility is great in and of itself, but it also promotes so many other things via the engagement that it creates that is worthwhile. I can say doing the impacts program has showed a significant increase in the NPR scores that we've seen prior to this particular assessment. And that's something that other folks can entertain that would, again, have cross influences for other efforts that EMSC does.
Thank you. Candace.
Debbie, we've got a question in the chat. We've got a question from Greg Edwards. It's, did you experience pushback and how did you resolve it?
I can speak to that since it's a sort of a spontaneous question. In my state, and this may come up in a future question in this session, but there was, again, just to reiterate, I do not sit at the state of New Hampshire's Bureau of EMS. I'm in an academic facility. But I can tell you that my predecessor was unable to get any sort of recognition program off the ground based on the state's denial of permission to her to start something. So having started through the EMSC program rather than through the state level organizations, we've actually had less pushback. And I think that the approach of creating a program, showing that it works, and then presenting it to the state is actually going to provide less pushback than what my predecessor experienced, which was a complete and utter, no, we will not do this.
All right, thank you, Anna. Candace, what about, did you have any marked increases that you've been able to show for West Virginia?
Yes, so it's not something that I've quite personally seen yet, but our program, the committee was formed in 2009, and sorry, my cat wants to join our presentation. And then the first ARC visits were done in July of 2011. And so I know that having that facility recognition program, and kind of, she had like a big meeting where she invited all the hospitals to come and hear about the ARC program. And that really sparked and pushed people to participate in the NPRP assessment. And she was able to look through that data and see that the facilities that were participating in our facility recognition program had significantly higher scores on the NPRP than other hospitals. And so that was something that really garnered interest in the program and helped it become more known throughout our hospitals here in West Virginia. And as we participated this year in the NPRP, it was kind of the same thing. Hospitals that were recognized were they were some of the first hospitals to respond to the NPRP. They knew, all the questions, where all the equipment was, and they got it done really fast right away. And other hospitals that hadn't really been as involved in our facility recognition program were ones that took a little bit longer to complete that assessment. And so I'll be really excited to go back and look at that data as compared to what the data was previously and see how those scores have changed.
Great, thank you. Evelyn, what about Illinois? You've got the long program there. Did you see, how do you measure increases?
So where we've seen improvements actually have been in the emergency department quality improvement activities. As part of our facility recognition requirements, there are quality improvement monitors that the hospitals need to conduct. And then in addition, our state is divided into 11 EMS regions, and each region through the facility recognition program is required to have a pediatric quality improvement committee. And then the recognized hospitals within each region need to participate on that committee. And then they identify a regional quality project that they all work on together. And so we've been really pleased with the kind of improvements that we've seen both at their hospital QI level as well as the regional level. So things like many times they're just looking at process improvements rather than quantitative, but they're still making progress, even if it's just looking at vital signs and pain assessment, child abuse screening, interfacility length of stay parameters that they've set up. So there's been a number of activities that they've done at the regional level, and we've been really impressed with the data, and they'll share that data with us at their site surveys, as well as at our state quality meetings. And then we've also done some data analysis with mortality, and we actually found that there was an improvement in pre and post EDAP. So we had hospital discharge data from before hospitals participated and then looked at their mortality after. And we actually found a significant difference in a beneficial way from before they were EDAP to after they became EDAP. So the mortality rate actually declined. And then lastly, we're hoping to be able to see an increase in their PEDS Ready scores. So we're looking forward to churning through that data and seeing what that shows us.
Perfect, thank you. Brandon, we haven't heard from you for a while. Have hospitals shared any quantitative or qualitative data about positive patient experiences and outcomes since participating in their facility recognition?
No, next question. No, I'm just kidding. No, they haven't. We're babies. We're just getting started in this. I've certainly had anecdotals, but nothing data wise. At this point, I guess part of the problem is on me, because I don't even know the questions to ask. Does that make sense? Because Wyoming's program is designed around improving NPRP scores. It's really not, I don't know why I keep saying that. The PEDS Ready scores. It's built around improving that as a step one. So I mean, NEDARC, you guys have had a good 48 hours now. Like, come on, man, show me how we did. Just picking on y'all. I know that takes a minute, but that's where we will see ours, because that's the way ours is designed. I believe that the data and the science shows that the higher your score, the better prepared you are, and the more likely you are to be set up for better outcomes and better experiences for your pediatric population. And so trusting in that, I built the system around something that we could touch here in Wyoming easily. I don't have access to discharge data and that sort of thing. We don't have any EPIs. Our entire state EMS office has a staff of 3. So we don't have that kind of infrastructure to dig off into that, even if we had access to it. But no, the short answer is no, but I absolutely believe it will come. And I think we'll see it. We'll see the start of that when our data drops out of this most recent PEDS Ready scores. I think we'll see those facilities improve.
Hey, Brandon, I'd say don't be hard on yourself. It seems silly from a perspective of a fellow colleague who has very few staff to work with that we would reinvent the wheel. I mean, the NPRA is a fantastic tool. It's extremely comprehensive. It's covered by national organizations and put out by national organizations. That I think that is probably the perfect tool to use for improving pediatric care.
Yeah, I appreciate that. And to answer, I didn't put an answer into Greg's question. So the answer is absolutely, I got pushback. you guys have known me, most of you, long enough to know now how I deal with pushback. I basically said, hey, I was looking for a job when I found this one, so I'm going to do the mission that I signed up for and what I said I was going to do. You're more than welcome to replace me, and I'm still here. So
We will build, they will come. All right. Next question. Have any hospitals or PECs become more involved with EMSC and pediatric readiness as a result from participating in the facility recognition programs? Tasha.
Yeah, in Tennessee, we have seen some more participation. It actually is kind of interesting because we've actually seen some elements of like competition between the hospitals. So like as they trying to improve what level that they're being recognized at. And so that overall improves all the care that's provided across the state. And it's also helped us, that's been our big push this last year, is getting PECs identified between the EMS and our different hospitals. And so having this recognition program already in place has helped that. So one of the things also to kind of go towards Greg's earlier question as well, for our state, we have a lot of different perspectives from the different hospitals when we're going through and updating our standards. So I wasn't here when we initially developed our program, but this last revision that we've done, it took them about 5 years. So it is a lengthy process. And the reason it probably took as long as it did is because of all the different viewpoints and what they want to be allowed for each of the different levels. They looking out for their own hospital. So one of the things that we always do before every meeting is just to re-ground everyone of why we're here. Put your employer, kind of in the back burner. You're here to help the kids across the entire state. We're here for a common mission. What is best for the kids and what is evidence-based. And so that's what we do when we go and add in our new standards. And so we're actually going through the legislative process right now with our most recent updates to our facility recognition program. And it now includes that as a requirement to have a PECC. So that is another way we've incorporated that to be able to help meet that performance measure as well.
Thank you. Candace, how about you?
So one of the ways that we've seen more participation through that is one of our large hospitals up in the north. They were one of our first to become recognized as through our program, and that kind of got the attention of some other people that were working in that hospital. And also we have our representative from the American Academy of Pediatrics works in the same hospital. So they kind of all got together and started a whole nother program that we now sponsor with EMSC. And it's through Project Adam, I believe is the national affiliate of it. And here in West Virginia, the program is called West Virginia Heart Safe Schools. And so we have partnered with various other entities in the state, a lot of them who work in the base group worked in that first hospital that became recognized. And they started a committee, and we've been able to purchase AEDs for schools in the state that do not have them. And then they started like an early detection program. So they send out a survey to all the school nurses that is supposed to go to all the kids' parents, asks them, certain questions to see if they're at risk for sudden cardiac death. And then that way, it's connected with our injury prevention program. And then if the school hasn't been trained on CPR and how to use AED, they go ahead and get trainers into the school. And then we're able to give them an AED for the school. So it's been something, so that program kind of grew out of that facility recognition program. And it's kind of really just taken off. And it's really cool to see how they're getting into the schools and how it's been going with COVID. Of course, it's been slowing down a little bit, but those key players from that hospital were able to kind of run with something else with the ideas that they got from that. So I thought that was really interesting. And it's a really great program. You can check out Project, I think if you just search Project Adam, you would find the national affiliate for it.
Very good. Thank you. Very interesting. Here's one I guess I'm really interested.
Sorry, Debbie.
Yes.
We just have one more question from Greg for the panel.
Okay.
Do recognized hospitals regularly share progress on improved internal measures or just report out when they apply for reapplication? And we have about 18 minutes left in the session.
Does somebody want to answer that? Somebody feel comfortable, Brandon?
My system's too new so no.
This is Evelyn, and we do not have them report out other than when we go through renewal, the renewal surveys with them. But the regional projects, they actually, the chairperson for each of those regional committees, they attend our state facility recognition committee, and each of them provide a report on their regional QI activity. So that's the only ongoing report out that we do receive.
If I can chime in as well, Greg, if you're in the stages of creating a program, you need to think about what your bandwidth is as far as, repeatedly checking in with facilities to see how they're doing, but also their bandwidth. This has already been brought up by Brandon, but it's a delicate balance between wanting to make sure that you're getting an honest assessment of a facility and flirting with becoming a JCO where you're walking in and being very regulatory. What we're talking about doing in the Northeast Always Ready for Children program is having something like an improvement plan that a facility would have to provide after they've been recognized. And, they've signed a commitment letter that said they're going to put effort into it. So between those aspects, you need to find kind of like a sweet spot, I think, with facilities. And let me preface that at the end that, our program is in its infancy. So we don't really know for sure, but that's how we're approaching it.
Thank you, everyone, for answering that.
Thank you so much for that response. Evelyn, one follow-up question for Evelyn is your renewal every 4 years?
It is. We do renewal of 2 to 3 regions a year. And so it takes us 4 years to get through all 11 regions, and then we start over again.
Okay, thank you for that. We'll turn it back to Debbie.
Okay, we've got quite a few questions, so we're going to kind of go through these pretty quick. This is one I'm interested in. What marketing materials or application approaches had the most positive impact on advancing your state's program? Anna?
Yes, so I'm trying to think of a better word for carrots or marketing materials, and the best I've come up with is positive influencing items. The badge buddies have been a super big hit both in hospital emergency department providers, but also your pre-hospital providers. So that's a great resource to invest in. And you can get the badge buddy off my poster within the QR code. And then we also have a resource for CT scanning to minimize pediatric exposure to imaging. And I'll stop there.
Brandon, how about you want to add anything?
Yeah, for us, the actual recognition book itself, the way that it's designed with 3 different ways for them to go through it. One is very rule language like, another is very checkboxy, and the other is very plain English, and they're all part of the same 3, or they're all 3 part of the same book. And the checkboxy version I give them is actually the exact same thing I use to check them off. And I tell them that on the front end, that this thing right here is what I'm bringing to check you off on. So they know however they like to approach things, they have 3 different ways to do it. And probably the other one is the plaque that they get. I wouldn't have thought that would have been so meaningful to folks, because you've seen a hospital, right? They're full of plaques and stuff. This one I tried to design different so it didn't look like any other plaque they had. But they love it. All 4 of our recognized facilities have on their own decided they're going to mount it right next to their registration desk. So it's the first thing everybody sees when they come in. Although right now they're probably covered with mask signs, but yeah.
Very good. Evelyn, has anyone developed and sustained a working group in their state related to a facility recognition?
Sorry, I just need to unmute. Yes, we do have a standing committee, and it evolved from the task force that we developed when we first started the process. So when we first started, we asked our hospital association as well as representatives from key professional organizations such as our state ACEP, AAP, ENA. We also brought on family practice and also a number of other groups as well to lend their expertise. And so the work of that task force took a couple of years for us to pull together the requirements, outline a process, and begin the effort. And actually, initially, we were planning to move in a mandatory direction, and then got some pushback from hospitals. And then the hospital association told us that they would not support a mandatory process, only a voluntary. So we needed to kind of go back in another direction then with that. But we still continue to move forward. And we just realized that over time, there were constantly issues or documents that needed to be updated. And also resource development that was needed. And so we used that committee to do that as well. So over time, it evolved from a task force that was initially convened just for what we thought was going to be a limited amount of time to then becoming a standing committee. And that group meets every other month. And believe it or not, we always have a full agenda and information and documentation that needs to get reviewed and get their feedback on.
Thank you, Evelyn. Brandon, on the financial side, what are the financial implications of participating in facility recognition program in Wyoming?
None that have been identified. That's a question I've actually asked. How much did this cost you? And certainly they talk about time. It's been pretty time consuming, especially those agencies that needed to develop policies and such. So as far as hard numbers, haven't had any. Mostly it's time, payroll dollars of putting everything together. Because even though my system's simple, it requires a lot of work, especially if you don't already have all those ducks in a row. But that's all I've been told is time. Now I've given them certainly financial aid through the EMSC grant for we in Wyoming, we have a problem with crash carts. We don't have, most facilities that I've come in contact with do not have a designated place for all their pediatric stuff to live. So I bought several crash carts for hospitals and they were really appreciative.
Great. Wonderful. Thank you so much. I'm just moving kind of quickly along so we can pick up a couple of more of these. I think we're just about done. Anna, turnover. Do you have any managers? Do any managers have experience taking over a program that wasn't already in progress from a prior state manager?
Yeah, I'll try to make this quick. I've sort of already touched upon it, but my predecessor was completely and utterly told no for a pediatric medical recognition program. And just if you come in and you're having the same issues you're having with your state, find a way to approach the house instead of through the front door, but going, through the window or the back door. Find a different approach where my predecessor just accepted the no. Sometimes you've got to find a better way to get in.
Great. Thank you. This is all such great information. I think we're going to move on to the COVID-19. Evelyn, COVID-19, how has it impacted your current pandemic on your facility recognition program?
It delayed our surveys. I mean, we have a standing schedule for, as I said, 2 to 3 regions per year that we go out and do renewal applications with the hospitals and surveys. And those 2 timeframes every year that we do are spring and early summer, and then fall and early winter. So obviously last spring is when everything was really hitting the fan. So we needed to delay those surveys. Actually, those surveys were scheduled in the rural part of our state in Southern Illinois, and those hospitals in that area of the state wasn't hit as hard at that point. They have later become more impacted by the surge, but so they were actually asking when we were going to come, but we got tasked with COVID responsibilities, so we weren't able to, we just didn't have the bandwidth to move forward with surveys at that point. So we did talk with them about doing virtual surveys. They were open to that. We put together a process. And so by August, we began implementing virtual surveys to address the surveys that were needed for those regions. And we've continued to refine that process and move it forward. We were hoping we'd get back to in-person this fall, but that hasn't happened. So we're continuing with virtual. And we know that we've lost 2 hospitals that withdrew, and we think it probably was related to COVID, although they just said that they've been just overwhelmed and just feel too challenged right now.
I think we've all really have adapted to learn Zoom this year on what all we can do to have our meetings and everything go on. So Zoom has been our friend. We're learning it better and better. So another great idea. I'm going to jump down to what hurdles do you face in state government recognition of these pediatric readiness? Candace?
Hi, so being housed in state government definitely makes things, I feel like, a little more difficult, although I don't have an experience to compare it to. One thing that I really face that I find is difficult is our program is completely voluntary, and it's always going to be completely voluntary. The only way to mandate it would be to get something passed in the legislature to force the hospitals to participate, and making something mandatory, I don't know how successful that would be anyways. So we're always tied into what, is happening in our legislative session. And that's where all of our, policies, procedures, guidelines, anything like that comes from. And so that it's kind of difficult to get a buy-in sometimes from the facilities when they know that it's something that's just voluntary. It kind of takes out like the incentive, or it just makes it more difficult. I don't changing things at a legislative level just it's not going to be realistic with that program. I think it was something that my predecessor tried in the past and couldn't get any backing for it.
Brendan, what about you?
Oh, I figured you was going to ask me. Yeah, I mean, they're there. It's I don't have any good solutions or ideas to give you because everything's different. Like my state tends to, if it doesn't involve improving the volume of coal that comes out of the ground, then most of the time they're not interested in talking about it. The strategy that's worked for me is, fortunately, in many ways, I have the power of the pen because of my other job. So I can force a lot of things, or at least I used to be able to, could force a lot of things into action just through my influence with regulating the state EMS office, right? And trauma fell under us. I never had to do any of that with trauma because our trauma program has been 100% on board with what we're trying to do. But unlike West Virginia there, in West Virginia, by the way, we should talk sometime. You probably do actually have some ability to weave your way in there. I can help you talk through some of that. But in our state, we could put trauma rules in place that require it. We could do that tomorrow. I got the power of the pen, right? The problem is when you do that, you're basically, at least from my point of view, I feel like if you do that before you have buy-in, then you're putting your hospitals, whether they want to be or not, automatically in an adversarial position. And you catch more flies with honey, you know. So our approach has been just holding out the honeypot and just trying to find ways to help them walk our way while I'm sprinting their direction, right? That's the model. You take a step my way, I'm going to walk 2 miles in your direction. And they see that. Not so much during a pandemic, but they see it. But yeah, I mean, there's tons of hurdles. I guarantee you all of ours are the same. They just look different. So it's just a matter of getting creative. I can tell you what won't work is do the same thing everybody else did, just like those that were talking about their predecessors. If you want to fail again, keep doing what they did if it didn't work for them, right? So get crazy, try something different, take some risks, and watch what happens. Sometimes read what Thomas Edison said about the light bulb if you don't already know that. It'll change you.
Brandon, I love your analogies.
Debbie,
let's
we've got just 2 or 3 minutes left.
Okay, let's ask another question here, quick. Natasha, is there anything you would have done differently in starting your program?
I wasn't here when they started the program, so I can't say for sure, but I know from the last few years where I've been participating in it, I think they've had a really good foundation for the program, the way they have it set up. In some aspects, it has made my job so much easier, having it being in our legislation, making it a requirement for all of our hospitals to participate. It's made it easier for me reaching out with like the NPRP assessment and other things that some initiatives that the state has, because everyone's already well aware of the EMSC program and what we do and some of like the goals that we have and some, the performance measures. And so it's been easier for us to be able to get some buy-in because of that. But again, it's still just a lot of trying to build those relationships with the people at the hospitals and making sure that they understand the why. I think that's been very important in the last few years, especially as we've been going through and doing some updates to our standards.
Well, as we bring this to a close, I want to thank everybody for being on the panel today. And I would suggest Nebraska, we're just starting this out too. We have our application packet. I have one that's joined now for us. So reach out to the ones that have been out there working. All these people have answers and can help you through it. So don't be afraid to ask. You have a lot of people out there working on this and you're not alone. So with that, thank you everybody for joining our session. We've enjoyed it. If you have more questions, just reach out to these individuals and I know they will help you. Be safe.